Hello everyone! Welcome to our channel, EasyMed. In this video, I am going to talk about one of the well-known medications, Bupropion. This drug comes under the brand name Wellbutrin, among others. Bupropion is a free base that's available as a hydrochloride salt. This centrally acting drug is available as a tablet in various brands and even generics. Among the brands, Bupropion is as popular as Wellbutrin, Wellbutrin SR, and Wellbutrin XL. It's also available as Zyban. The first formulation, Wellbutrin, contains bupropion hydrochloride as an immediate-release tablet. Due to lower patient compliance and more pronounced side effects, this formulation is nowadays replaced with slow-release dosage forms. The last three formulations fall into this category. Both Wellbutrin SR and XL release bupropion hydrochloride in a sustained and controlled way, but they are not equivalent in their rate of drug release. Zyban is another extended-release formulation, but it was discontinued recently. Bupropion XL is another extended-release formulation that contains a high dose of bupropion hydrochloride at a strength of 450 mg. This formulation can be used under specific conditions where a high dose of bupropion is required to treat depression. Bupropion is also available in another salt form as bupropion hydrobromide. It is available under the brand name Aplenzin with different dosage strengths. In this video, let's discuss a few of the interesting points about bupropion. We'll talk about things like how to use this medication and how it treats depression. We will also go through scenarios where this medication should be avoided or used carefully. We also discuss the adverse effects of bupropion hydrochloride. First, let's start with some information about this medication. Bupropion is an atypical antidepressant indicated for the management of major depressive disorder. Depression is a central disorder that is often associated with a few symptoms like agitation, a lack of interest in doing daily activities, slow thinking, and a feeling of guilt and worthlessness. It may often be associated with changes in eating habits and sleep patterns that may result in either a lack of sleep or enhanced sleep time. When any few of these symptoms persist for a longer time with supporting risk factors, it may be classified as major depressive disorder. In such conditions, bupropion can be used as first-line therapy. Bupropion is also indicated for the management of smoking cessation in people who are intentionally ready to quit smoking. For this purpose, Wellbutrin XL can be used at a dose of 150 mg. Now let's see how to take this medication. We have already seen two formulations of bupropion hydrochloride, Wellbutrin SR and Wellbutrin XL. Here, their term SR indicates sustained release, whereas XL indicates extended release. Even though both of these are slow-release formulations, they are not equivalent due to the difference in their rate of release. From Wellbutrin SR, bupropion is released over 12 hours, whereas from Wellbutrin XL, it is released over 24 hours. Wellbutrin SR is available in three strengths: 100 mg, 150 mg, and 200 mg. For the treatment of major depressive disorder, it is given at an initial dose of 150 mg once daily. After 3 days of treatment, the dose can be increased to 150 mg given twice daily, so the total daily dose is 300 mg. The maximum dose of Wellbutrin SR is 400 mg per day, given in 2 divided doses. Wellbutrin XL is available in 2 strengths, 150 mg and 300 mg. This drug can be used for 2 conditions: major depressive disorder and seasonal affective disorder. For both conditions, this formulation is given at an initial dose of 150 mg once daily. After 4 days of treatment, the dose can be increased to 300 mg per day, given in 2 divided doses. In the case of seasonal affective disorder, dose increments can be made after 7 days of treatment. Now let's see how bupropion works. Within the CNS, presynaptic dopaminergic neurons store dopamine, and on the postsynaptic neurons, dopamine receptors like D2 are expressed. The release of dopamine is controlled by calcium channels located on presynaptic nerve terminals. When these channels are activated, calcium can enter the neuron, leading to exocytosis and the release of dopamine. Dopamine binds to its receptors on postsynaptic neurons, which results in their activation. As D2 receptors are inhibitory in nature, their activation results in decreased levels of cyclic AMP. The action of released dopamine is limited by its uptake into the presynaptic nerve terminal. This uptake is carried out by a special dopamine transporter, DAT. Wellbutrin can block this transporter so that the released dopamine is not taken into the nerve terminal. This enhances the binding of dopamine to D2 receptors, leading to increased dopaminergic transmission. This improves symptoms of depression, elevating the mood of the patient after a few weeks of therapy. A similar mechanism is also observed in noradrenergic neurons. The entry of calcium results in the release of norepinephrine into the synaptic cleft. Again, some amount of released norepinephrine is taken back into the nerve terminal through the norepinephrine transporter, NET. Here again, Wellbutrin blocks this transporter, thereby inhibiting the uptake of norepinephrine. This increases noradrenergic transmission, again elevating the mood in depressed patients. What are the important precautions for bupropion? Bupropion should be started initially at a low dose and gradually escalated over a few weeks to prevent any adverse events associated with high doses. It is started at a dose of 150 mg, and after a few days, it may be increased to 300 mg. Further dose increments can be made up to 450 mg. The risk of seizure induction increases with higher doses, particularly in the dose range of 300 to 450 mg. The seizure induction can also be further increased by a few of the risk factors. Patients with any recent head injury, central tumors, or a recent stroke may have a high chance of getting seizures with the use of bupropion. In patients with bulimia nervosa, the risk of seizure induction is again high with bupropion. So in all these conditions, the use of this medication is not recommended. Co-administration of a few of the centrally acting drugs may also increase the risk of seizure induction with bupropion. For instance, drugs like TCAs, antipsychotics, bronchodilators like theophylline, and even corticosteroids can increase risk of seizures. Sometimes, sudden withdrawal of drugs may also increase seizure induction in the presence of bupropion. Benzodiazepines, barbiturates, and antiepileptics are groups of drugs that reduce seizure potential, and when these drugs are suddenly stopped, they may increase seizure tendency. So while using bupropion, these drugs shouldn't be stopped suddenly, and a slow reduction of dose is suggested. Similarly, sudden withdrawal from alcohol can also precipitate seizures in the presence of bupropion. In a few people, mood swings can be observed between depression and mania, and vice versa. These mood swings can be observed in people with bipolar depressive disorder. In such patients, bupropion shouldn't be used to control depressive symptoms, as it may increase manic or hypomanic phases. In the case of any family history of bipolar depressive disorder, bupropion is not suggested. Bupropion can cause pupillary dilation, which may increase intraocular pressure in people with narrow angles. Therefore, this drug may increase the risk of angle closure glaucoma in susceptible patients. Another important effect of bupropion is to induce psychotic symptoms. Use of this medication may result in hallucinations in the form of either auditory or visual perceptions. So one may feel some strange voices or visuals within the surrounding environment even without their physical presence. You may also experience delusions and confusion during the treatment. Monoamine oxidase inhibitors are one category of drugs indicated for the treatment of depression. Drugs in this category include phenelzyne, tranylcypromine, and isocarboxazid. These drugs shouldn't be co-administered with bupropion as it causes elevated blood pressure due to the precipitation of the cheese reaction. Now let's see the adverse effects of bupropion. Common side effects of bupropion mainly include insomnia, dry mouth, dizziness, and abdominal pain. It can also increase anxiety and agitation. Tremors can be observed in a few people. Myalgia, that is muscle pain, is also seen with this medication. Other side effects include sweating, palpitations, headaches, and skin rashes. Serious but rare side effects can be observed at higher doses, greater than 300 milligrams, and in people with associated risk factors. Just like many of the antidepressants that affect serotonin levels, bupropion can also increase suicidal initiation in young and adolescent people. It can also increase the risk of seizures in patients with any of the risk factors that we have already discussed earlier. Pharmacokinetics of bupropion. Food doesn't show any significant effect on the absorption and bioavailability of bupropion, so it can be taken either with food or without food. It is metabolized by the liver into hydroxybupropion by the CYP2B6 enzyme. Drugs like ritonavir, lopinavir, and efavirenz can inhibit the expression of this enzyme, thereby reducing the metabolism of bupropion. So these drugs should be carefully combined with bupropion, and the dose may be reduced to avoid its toxic effects. In cases of renal impairment, with a glomerular filtering rate less than 90 milliliters per minute, either dose reduction or increasing the dosing interval may be required. Similarly, in patients with severe hepatic impairment, the maximum dose of bupropion is limited to 100 milligrams, otherwise, it can be given at a maximum dose of 150 milligrams on alternate days. Now let's see the chemical form of bupropion. Simply put, it has a phenyl ring with a chlorine group that is attached to a ketone side chain with 3 carbons. Since the ketone group is directly attached to the phenyl ring, it is a phenone derivative. As the side chain has 3 carbons, the entire structure will be propiophenone. The ketone chain is further attached to the amino group at the second position. That's why bupropion is an aminoketone derivative. This group is a tertiary butyl amino group. The name bupropion can be derived from these two moieties. The prefix bu can be derived from tertiary butyl amino, and the suffix propione can be obtained from propiophenone. That concludes our discussion of Bupropion's pharmacology. Thank you for joining me today to learn about this medication. I hope this video provided valuable insights into how this medication works. Don't forget to subscribe for more informative content, and remember to consult your healthcare professional for personalized advice. Stay healthy and take care.